What is the cost, if you know, of one fracture to an individual and to the system? How much does it cost?
Depends on what type of fracture we're talking
Okay,
about.
let's
But
say
let's
a
take
hip
hip.
fracture.
Let's
Yeah.
take hip. When you're talking about all costs, so both inpatient hospitalization, the direct costs, and then the follow-up indirect costs, we're probably talking about somewhere upwards of $35,000 to $40,000, maybe up to $50,000. It depends on the payer.
I would think higher,
Yep.
frankly, because of the surgeon's fee, the
That's sort
hospital
of
fee.
first year. That's not subsequent years in terms of additional
All right.
care that's needed.
So I will again put this out there, for a $20,000 one-year expense, you could reduce hip fractures, if I remember the number you told me, 50%? Was it 50? 38%. 38%? So $20,000 gives you a saving of 38% of the time, $50,000.
It's also interesting when you think about it compared to other disease states. And maybe, again, if we're going back to talking about ageism, there's something to do with that. But, when we look at the population for osteoporosis, but if you're looking at a multiple sclerosis patient where the treatment is $80,000 a year, but the population is younger, and that gets cleared pretty easily, why is it that for our older patients, we're not able to do that?
But there's the dreadful number, which you hear all the time, years of life.
Yeah.
In other words, the cost per year of life. That's ageism, no?
But I think the way we have to start looking at hip fractures are, what if, 1 year later, what if someone's really, really functional? That is an incredible success story, and I think there's more onus on us to treat that patient differently because they've done so well. So number one, we don't see it. In our fractured population, 15% of patients, all fractures together, 15% are dead by 6 months. If we talk about men, 20%. So number one, it's an incredibly severe event, life-threatening, and it's balancing that, it's balancing long-term costs, it's balancing being stewardly. Clearly, we do not want every patient with osteoporosis on these drugs. I think it gives us strategies for the more severe, the more risky patient that over time will modify and be better with.
Wait, I want you to run that back for me. Those are numbers, I've heard a lot of numbers. Haven't heard those. The death numbers. Mm-hmm. What was that? What were those percentages again?
So this is just in our program, and it's consistent. Over the last 10 years, all fractures, we just started to say, are they at 6 months? So we don't even know why we chose 6 months as opposed to 1 year, but that's the way we did it. 15 to 20% of those fractured patients are dead because of comorbidities, the kind of things that happen in the immediate post-fracture period.
Let's recast this. We have been discussing osteoporosis in terms of lifestyle, impingement on the things you want to do, going forward, being someone who is less than you would like to be. You told me that a fair number of these people in the 20% range are simply dead 6 months later.
6 months to a year, yeah.
Yes, that is a number that nobody has heard. I haven't heard it. It's huge. And if we're talking $20,000 for a drug that will have a significant impact on death, now you're up there, heart disease, breast cancer, other lethal diseases.
Well, we beat those numbers. So for nationwide, it's about 25%. We say 25% of people die within the first year after a hip fracture. So that's 75,000. There's 300,000 hip fractures. That's 75,000 people a year. That is more than women who die from breast cancer. Yet we, as a society, spend so much time and concern about breast cancer, which we have to, but this is also happening every day in osteoporosis, and people do not know.
That's called burying the lead in the news business. Oh, it's bad. You're going to have to use a walker. You're going to have height loss. You're going to have pain. No, you're going to be dead. Why am I shocked by this? Did I miss this?
Well, number one, I don't think, we're all looking for the way to get this message out.
I think you just found it.
And it resonates.
But I think it's a little, again, like we talk about where the patient falls in this, and obviously from the patient advocacy organization side, that's where our focus is. So we've put out these messages several times to patients because I think the same thing. I think one of the problems with this disease state is, unlike breast cancer, we don't have an army of women demanding DEXA and demanding treatment options and demanding these things as they did when that movement happened for breast cancer. And I think part of that is because they, as Andrea has said, they don't want to hear that message. So when we've tested messages with patients, and I anticipated it would be this when we actually did the survey, it was, we had half the patients when we told them, you know, there's going to die, 25% of people die within the first year of a hip fracture. Half of the patients responded, how dare you give me these scaremongering, statistics. You're supposed to be hopeful. And half of the patients said, oh my God, I had no idea. Thank you, I'm going to my doctor right now. Right? So it really depends on the patient. And as we talk about personalized care, I think, and it's really, I know the burden that physicians have trying to get all this information to patients, but it is an individual message for the patient. It's determining whether the patient will be inspired by the, hey, you might die, this, or hey, I want to keep you mobile, and let's look at your, as you said, look at your activity level and all of those things and determine what's best.